left hemiparesis due to stroke. Next slide. So for past medical history, patient had diabetes mellitus, which was diagnosed approximately 10 years ago at Clinic Pasimas. Initially, patient presented with lethargy, polyuria, and also polydipsia. And then currently, patient was on metformin, and he claimed that no side effect from the drug, and claimed to compliant to the drug. Patient denied visiting any dietitian, but was advised to reduce the sugar intake. And patient went to clinic once every 6 months for follow-up, and there's no complication like macrovascular and microvascular complication. Patient claimed that he had occasional hypoglycemic episode, but no hyperglycemic symptoms, and he had no history of admission due to hypoglycemic emergencies. For
Actually, sorry. Yeah, I can stop you here. So the left hemiparesis that you mentioned due to stroke, is that not considered a macrovascular complication?
Oh yeah, true, doctor.
Yeah. So I think, yeah, don't be too fast into saying no complications. And are you also sure the patient did not have any proteinuria?
Proteinuria. I'm not sure.
Sometimes the thing is, patient with diabetes mellitus, if they are follow up at the Ministry of Health clinics, sometimes they would have a booklet. You can ask the patient whether they have any booklet or not. In the booklet, they sometimes will tell you what are the tests being taken, what will be the result of HbA1c, what are the drugs that have been taken, have there been visited any ophthalmology or not. So you can verify your history with that booklet that the patient may have. So where did the patient follow up for his diabetes?
Clinic Pasimas.
So did you ask him about the booklet?
No, I did not.
So next time, go and ask the patient.
Okay, doctor.
Okay. All right, go on.
So next is for ischemic heart disease. It was diagnosed in 2015, in which patient was presented with chest pain and profuse sweating, and he was admitted to ward in HRPZ. And on the day of admission, patient developed stroke with left hemiparesis, and he stayed in the ward for 2 weeks and then discharged. And patient went to follow up once every 2 weeks at the Clinic Pasimas, and he claimed to compliant to the medication and also the follow-up. So for hyperlipidemia, a patient was diagnosed with hyperlipidemia since 2015 during the diagnosis of ischemic heart disease. And he was on tablet atorvastatin, and he claimed to compliant to the medication. And for hypertension, patient denied having hypertension, but he was given antihypertensive drugs, so history couldn't taken from him. And then for benign prostatic hyperplasia, it was diagnosed in March this year at Clinic Pasimas, in which he presented with reduced urine output, incomplete bladder emptying, and also bilateral swelling. And ultrasound was done, and then he was then given medication, and the symptoms resolved. For hospitalization history, this is currently he is on second admission. So for first admission, it was due to the ischemic heart disease, and there's also no surgery done before. For drug history, this is the list of the old medication patient was having. He was on metformin, cardiprine, bisoprolol, perindopril, atorvastatin, isosorbide dinitrate, and neurobion. So, however, currently he was on pantoprazole, intravenous Lasix, metformin, cardiprine, atorvastatin, and neurobion. Furthermore, patient had no known drug allergy and he did not take any supplements and and also no other traditional medicine. For diet
I think
history,
I think I stop here now. Just go to the physical finding.
okay. I'll pass to Manpreet.
Great, good morning to everyone and Prof. I'll be talking about the physical examination. So on general inspection, my patient was lying flat on the bed with his head supported by one pillow. He was alert, conscious to time, place and person. He was not in pain. He was also not in respiratory distress. His respiratory rate was within the normal range, which is 19 breaths per minute, and there was no evidence of usage of accessory muscles. For hydrational and nutritional status, both were clinically adequate. There was no evidence of muscle wasting, and also for hydration, there was evidence of moist lips. Coloration, he was not pale or jaundiced. For attachment, he had nasal prongs and a Foley's catheter, which was attached to an empty urine bag. There was a presence of a walking stick beside his bed, and there were no gross deformities seen. For peripheral examination, so his vital signs, all of them were within a normal range. His temperature was 36.8, pulse rate 64 beats per minute, blood pressure 124 per 90 millimeters of mercury, and then his partial pressure of oxygen was 100. SpO2, was 100%. For hand examination, his palms were pinkish, warm, and dry. There was no evidence of palmar erythema or Dupuytren's contracture. There were no tender osseous nodes or non-tender genuine lesions. The capillary refill time was less than 2 seconds. There were no splinter hemorrhage seen on the nails, no peripheral cyanosis, no clubbing, and also there was no tendon xanthoma. For arm examination, his radial pulse was palpable. The rate was 64 beats per minute. The rhythm was regularly irregular, good volume and character. Regularly irregular probably is actually a characteristic. It's quite normal during inspiration and expiration for the rhythm to be regularly irregular. So there were no bruises, purpura or petechiae seen on the patient's arm. And then for axilla, there was no loss of axillary hair because he has type 2 diabetes mellitus. So, and I also saw if he had acanthosis nigricans, he didn't have. For face, no wasting of temporalis muscle. For eyes, he did not have xanthelasma, no jaundice, or no conjunctivitis. But then there was presence of arcus sinalis. Because of his dyslipidemia. And then for mouth, no angular stomatitis, no glossitis, no central cyanosis, and he had good oral hygiene. For the neck, there was no anterior neck swelling. JVP was also not raised. However, his trachea was slightly deviated to the right. There was more space, about 2 cm more to the left of the trachea compared to the right. For lower limbs, both his lower limbs were swollen up to the knee level. The left leg was slightly larger in size compared to his right leg. There was no redness of both his lower limbs. There were no scars, no bruises, no petechiae or purpura seen. There were also no dilated veins of his lower limb. However, there was presence of pitting edema. The left leg was up to his knee and his right leg was up to level of mid-shin. For specific examination, cardiovascular examination was done. On inspection of his chest, there were no chest deformities, no scars, no dilated veins, and no visible pulsation. For palpation, the apex beat was palpable, but it was palpable at the 6th intercostal space, and it was slightly to the left of the left midclavicular line, like in between the left midclavicular line and anterior axillary line. There were no trills palpable at all 4 valvular sites, and there were no parasternal heaves. For auscultation, normal S1, S2 heart sounds were heard at the apex of the heart, and there were no murmurs heard at all 4 valvular areas. For respiratory examination, on inspection of the chest, like I said just now, there were no chest deformities. The chest moved passively and symmetrically with each inspiration. So there was no reduced chest expansion. There were also no visible pulsation or dilated veins. There were no indrawing of intercostal or subcostal spaces. On palpation, my patient had equal chest expansion. Like I said just now about his apex beat, palpable at 6 intercostal space. His trachea was slightly deviated. Tactile parameters was normal and symmetrical at 3 lung zones. On percussion note was resonant bilaterally at all 3 lung zones. The cardiac and liver dullness were present. On auscultation, there was equal air entry bilaterally in all three lung zones. The breath sound was equal in intensity and vesicular in nature. There were fine crepitations heard at the lower zones of both lungs. Vocal resonance was not increased and equal for both lungs. Abdominal examination was done. On inspection of the abdomen was flat and it moved symmetrically with each inspiration. The umbilicus was centrally located and inverted. There were no scars, no dilated veins or pulsations seen on the abdomen. The cough impulse was negative. For superficial palpation, the abdomen was soft and non-tender. Deep palpation, no mass was felt. Palpation of the liver and spleen, both the liver and the spleen were not palpable, but on percussion, the liver span was measured to be 12 cm at the right mid-clavicular line, which is slight hepatomegaly. For spleen, the spleen could not be percussed, and there was slight shifting dullness present. On auscultation, normal bowel sound was heard at the right iliac fossa of the abdomen. For neurological examination, since he has left hemiparesis, so we did it. So for the upper limb, on inspection of both his upper limbs, there were no scars, no abnormal movement, such as no tremors, and also there were no fasciculations seen. There was also no muscle wasting of both his upper limbs. Tone, his right arm was normal, but his left arm was heavy and slightly hypotonia. And then for sensation was normal for both upper limbs. Reflex, both his upper limbs were normal. For cerebellar sign, this diadochokinesia was normal. The finger nose test was also normal. There was no pulse pointing. For power, his upper limb was normal, but then his left upper limb, it showed a decrease in power, where he was only able to lift his arm. He couldn't resist the resistance. For lower limb, inspection is the same as upper limb. There were no scars, no abnormal movements of the lower limbs, no tremors or fasciculations here, and no muscle wasting. The tone of his right leg was normal. His left leg also was heavy and slightly hypotonia. Sensation was normal. Knee-jerk reflex was the right leg showed normal, but left leg was like hyperreflexia, and then Babinski sign was positive. For power, his hip for right side was normal lah, but then his left side hip was he couldn't resist the resistance, but then his leg and foot was about 4 out of 5.
Sorry, Manpreet, when you say the Babinski is positive, do you mean the toe is upgoing?
Yes.
Okay, all right. Continue.
So I will pass to Kaming for diagnosis.
But this one you don't have to show. We will discuss this.
Okay. I will continue with the investigation. So the first investigation that
You can stop here, Manpreet. You can stop here now. Now we open to the floor for questions. No, don't show this slide also. You don't have a summary slide? In that case, then don't have to show any. Maybe just show to the first slide. That's fine. Now open to question, because if you're not.
I have a question, doctor. On the HOPI, coming, you mentioned about shortness of breath. You said that it was 2 days prior to admission. So was it the same level, or did it worsen on the second day of admission? The second day. Can you hear me?
Yes, Hashini.
Yeah.
I think I just asked him for the shortness of breath, but I didn't ask about the progress of the shortness of breath.
Oh, okay.
So sorry.
Thanks, Kaveh. No, it's fine. Thank you, sir.
Anyone else? If not, then I will start.
Sorry, I have another question. Regarding the bilateral leg swelling, did you guys measure how much the circumference of the leg?
Sorry, how much what?
I mean, how big it is for the leg, for the bilateral leg swelling? You guys like
Uh,
measure the.
No, we
we,
didn't measure.
Oh, okay.
we just do
And
the,
and,
it's up
and, and one
until
more.
below the knee. Yeah. Yeah.
Oh, okay. And one more, like for bilateral leg swelling, is it like say the swelling is both like symmetrical or like left side is more bigger than right side or how?
Right
You
was
got my,
larger
my
than the
question.
left.
All right, larger than left. Okay. Uh, that's all. What I want to ask. Thank you.
Danish, Danish Joe, right? Your name.
Yes.
What is your rationale for asking those questions? What are your thought process? I want to understand. Hello?
Yes.
You understand my question, right?
Yeah. I just like curious. Just want to know.
No, there's no such thing as curious in medicine. We are not we are not like in any other kind of occupation where curiosity may be needed, but we have to be professional. So we are not being creative or curious here. You understand, right? Because every question that you ask, you have to be precise, and you need to know the reason for asking. Because in when you are managing the patient actively in the ward or even in the emergency department, you cannot ask a question out of curiosity, can you, Danish?
I know that.
Yeah, there's no such thing as asking a question just out of curiosity. So that's why I'm asking you, what is the reason you're asking the size of the lake? What are your thinking process? Hello?
Maybe to know like to what degree the leg swelling is, like to what extent.
No, okay. This is not really the answer that I expected. You may want to think about if the leg is bigger on one side, then are you thinking the patient could have a deep vein thrombosis or not? Because the patient have, like what the presenter mentioned, bilateral leg swelling, they may
Or
increase the risk of having a venous thrombosis. So if one of the leg is more swollen than the other one, then in the back of your mind, you might want to think, could there be a venous thrombosis? That's why you ask the question. Faham tak?
yes, betul.
Okay, so next time, please don't ask question out of curiosity, but ask a question that you think is relevant to the case, and there must be a reasoning behind it. Okay, yeah?
Okay. Okay, sure dah.
Okay, next one.
Sorry, I would like to ask a question. Sorry, the
Who is this?
SOB,
Sorry, who is
the
Y31536444? You can tell your name. Next time, right? All of you should put your name. There's no Y31523349. You can put your number, but they must always follow by a name. Like Y31523349 is Farah. I think that's okay. Yeah.
sorry, Prof.
So who is this?
My name
What's
is
your
Hazel,
name?
Prof. Hazel.
Sorry, Hazel.
Uh,
Okay, go ahead.
for the shortness of breath, right? Carmen, you mentioned that he uses three pillows to sleep. That is like that is how he usually sleeps. Or he's using three pillows to sleep ever since he started experiencing like shortness of breath.
Yeah, since he got shortness of breath, then he used 3 pills. Before that, he used one only.
Okay, okay. Thank you.
Is that all you want to ask,
Doctor, I have a question
Hazel?
after all. Oh,
No. Before that, Hazel, the one who asked
yes.
the 3 pillow question. Tell me what do you want to know, or what is the rationale behind your question?
Because normally like when we ask uh example in symptoms of heart failure, right? Like sometimes people might experience shortness of breath when lying down. So they will try to prop up the amount of pillows when they want to sleep. But sometimes for normal people also, they usually sleep with two pillows because they like that propped up position. So I wanted to know, was it something to relieve him ever since he started experiencing it, or is that his normal number of pillows that he usually uses to sleep? Uh,
So what's the term that you use when describing patient who is breathless at a supine position?
uh, um, or, is it orthopedic doctor?
No, you should tell me. Is it or is it not? Please be more confident of yourself. Is this orthopnea or not orthopnea? Hazel?
I
Hello,
think
are you
is
there?
doctor. It could be orthopnea or paroxysmal nocturnal dyspnea. I'm not really sure about this doctor.
So how do you differentiate between the two? Hello, Hazel, are you there?
Um,
These two are very important point in the history, especially for this patient. So you have to be very clear on the distinction between the two. So what's the difference between the two? I'm sure you have read about that, right?
orthopnea is breathlessness in the recumbent position relieved by sitting or standing. For paroxysmal nocturnal dyspnea is the shortness of breath that awakens patient after 1 to 2 hours of sleep. And it's
So the
also
patient,
relieved.
okay, so is this patient having orthopnea?
I would say yes, because it is relieved by sitting up. Like Carmen didn't mention that it disturbs his sleep. So I would say it's orthopnea rather than proximal nocturnal dyspnea.
But did the patient have paroxysmal
Oh,
nocturnal dyspnea or not?
also yes, and also it woke him up from sleep 2 to 3 times a night. So orthopnea, sorry doctor, sorry prof. Orthopnea and
Aiyo.
proximal. Yeah.
Okay, never mind. Next,
Sorry,
who,
doctor.
who else want to ask?
Doctor, I want to add on something regarding
Yeah.
Hazel's question. I asked him if he had shortness of breath when he lie down, but patient denied. He only had shortness of breath when he was sleeping.
Uh-huh.
So I think he didn't have autopnea but have paroxysmal nocturnal dyspnea.
Okay, anyway, just go on with who else is asking, gonna ask questions.
I have a question. So regarding past medical history, you mentioned for diabetes mellitus, you mentioned that this patient is compliant to his drug, right? So how do you ask whether this patient is compliant? Uh, what I mean, maybe you ask his his latest BSP, or how do you know whether this patient compliant? Because
Uh, for him, I just asked whether he took the drug every time, but I didn't check for his BS blood sugar level.
so there's no recorded of his latest BSP or the diabetes bootleg as what doctor mentioned just now. So you didn't refer to that
Yeah,
lah.
I didn't check for his booklet. Yeah.
Okay.
Anyone else? If not, I can start. Who asked the question just now?
Me, Doctor. Farah.
Farah, okay. So I'm jotting down the names of people who have asked. Any more questions? If not, then it's my turn to ask you questions.
Prof, may I ask regarding the diet history? Is there any dietary changes or is there any what we call increase in salt intake for the patient? If a presenter have asked regarding this,
No, it's just normal adult diet.
normal
It
adult
didn't
diet.
change any. Yeah.
Okay, maybe it's my turn now. I have seen in the participant list there are two persons who have their phone there, but no names. You might want to put in your name. Also, there is someone 1502007, also no name. Please put in your name as well. Maybe I should ask 1502007 because are you there? 1502007?
Yes, it's me, Dr. Zul Irfan.
Zo, is it?
Yes, Doctor.
Okay, so maybe you can tell me what comes to your mind when you hear the history.
You mean the what might be
Do
the
you have
differential?
do you have a provisional diagnosis in your mind?
Yes. I think it is uh due to fluid overload, secondary to non-compliance to restriction of fluid.
There is actually no such diagnosis as a fluid overload. There's only diagnosis like, for example, congestive heart failure is a diagnosis, but fluid overload is not a diagnosis. So you have to tell me whether you think this patient has a congestive heart failure or is this an end-stage renal disease? What is it?
I think it's end-stage renal disease, Doctor.
Then tell me why.
Because of the
Hello?
um um because this patient have underlying hypertension, and then and then also have underlying diabetes mellitus, which is a risk factor for uh
Patient denied any hypertension. And the physical exam is 130 over 90. Will you consider that as hypertension?
not really, Doctor.
So what else? Lu? What other points are there in the history that are telling you this patient may have an end-stage renal disease? Do you know or you don't know?
I'm not sure, Doctor.
Not sure. Okay, give me a name.
My
Anyone
friends
over here?
and
Yeah, you
um
give me a name.
Faris, Doctor.
Faris. Is Faris here? Wow.
Yes, Doctor. I'm here.
So can you
Just
continue what your friend has mentioned? Do you agree with him? Do you think the diagnosis is end-stage renal failure?
first the first thing I thought will be the failure lah, Doctor. I agree
Which
with
one?
Azhar maybe.
So you agree. Then you must tell me why.
Maybe because the
There's no
uh,
maybe.
oh,
You
sorry.
the,
Uh,
mm.
because he might think about the reduced urine output as well, and the bilateral that study may indicate to kidney disease, as I think that.
So there is history of oliguria or reduced urine output. What else?
Hmm, I think that's two things that actually may result in its kidney failure. But at the same time, but for me, I
But
will.
the
Hmm?
patient also have a prostatic problem. So how do you know that oliguria is not due to his prostate?
Oh, yeah. For that to confirm, we should ask for.
You,
Hmm?
you need to yes, you need to tell me more information about that so-called reduced urine output.
Mm, output.
Are there enough information in the history to tell you this patient has a oliguria which is compatible in someone who has renal failure? What's the difference between oliguria in someone who has renal failure and someone who has a prostate problem?
Hmm.
Do you know or you don't know?
Don't know that. I actually don't know. Or should I
Then
pass this question to someone else that time? Because I don't know that.
yeah, give me a name.
Okay. Okay. The name will be. I think I want to ask for Nazirin, doctor.
Nazirin. I think Nazirin dia dah tanya soalan dah tadi.
Oh no. Okay. Okay.
He gave me
Uh,
another name.
I think the handsome Akil, doctor. Akil. I guess.
Akil, are you here?
Yes, I'm here, Doctor. Prof. Sorry.
Okay, so please help your friend.
The question part has been asked is the difference between decreased urine output between the person with BPH and end-stage renal failure, right?
Yeah.
Okay. I think it's in the patient with end-stage renal failure, the kidney itself did not produce a reduced amount of urine, but in the patient of the renal prostatic hyperplasia, because there is like constriction of the urethra, the amount is reduced due to the constriction itself, not the reduced urine production.
So how do you differentiate that in the history?
Is
What
there
about this
any
patient?
episode? For the patient, we can ask: is there any episode of dysuria, painful micturition, or hematuria?
So what does that tell you? Does it point to a prostate problem or what?
And that is pointing to the prostate problem.
What else?
And then PH.
What else about prostate problem? What other question? Have you done surgery before this?
Yes. Yes.
Then you should know, isn't it? What other symptoms that will accompany a prostate problem?
So urinary increase in urinary frequency.
Exactly. So the
Urgency.
frequency of the urine will increase. There will be a sense of urgency, incomplete emptying. So does this patient actually have all those?
Did not. He only mentioned that he has decreased urine output.
And how much of decreased urine output in this patient?
Did not tell in this patient.
Sorry?
In this patient, the history did not tell about the amount of decrease.
Not tell doesn't mean that it's not there. Do you ask? And how do you want to ask? So I give you a chance to ask the presenter.
Oh. Maybe do you ask the patient more about the ni
No,
urine?
sorry, it's not your turn already. It's Akhil's turn.
Alright.
So Akhil, please ask the presenter.
Coming or Pampit, can I tell me if you already asked the patient about the like amount of the urine, is it some reduced from the normal amount?
Yeah, I did ask. Patient said the volume is reduced.
Is
Akil, it's
Uh-huh.
like this when I asked the patient like how much did it decrease then like compared to normal, and then he said that the amount of times he go to toilet is increased. That means he had to go a lot of times, but then every time he went kan just drops very little. So he assumed that because of this like little just drop by drop keluar kan, so he just assumed that is for him lah, is less already. Like reduced urine output is not normal for him. He said usually will be a lot. Then this time it's just like drop, drop, drop like that, he said. And then after that, I asked him if he got like difficulty to start the stream or not. Then he said there is no difficulty to start the stream, but then he just that when he go to urine, when he feels like he wants to urine, it just drops. Faham tak?
So how else, Akhil, how else do you want to know whether there is an actual oliguria or not?
Actual oliguria, right?
From physical finding, the patient has a Foley catheter. So what can you use that information?
We can start the IO chat. The intake output.
Exactly. So that is another more objective way of knowing whether the patient has a reduced urine output or not. Do you want to ask the presenter, were there any recording done on the urine output per day from the Foley catheter?
Okay. Mampit or Kami, do you have any record? Did you see any record of the in the observational chat about the IO about the output chat?
Oh, we didn't.
Hmm?
We didn't see the chat.
Which you should, isn't it, Manpreet?
Yeah. Yes, we should have.
So doesn't mean that this patient you are only see only the history and physical examination, but when you think about the case, if this patient you suspect to have a renal failure, you have to know whether there is an actual urine output, a reduction in the urine output or not. But the problem I see in this patient is that he's on a furosemide. So that itself would have, in a way, would disturb the urine output. But if the patient is on a furosemide and yet there's no urine output, that would give you a clue that this patient does have a oliguria. Understand? Akil?
Understand?
So what else? So do you still think the patient has a renal failure or heart failure?
My I'm leaning on the heart failure as the provisional diagnosis.
So you don't agree with Faris and your other colleague, Zul?
Yes.
Okay, why? Why do you say why you don't agree with them?
Because the
Why you
patient
say
have
it's a heart failure?
because the patient have the symptoms of shortness of breath, and he also have paroxysmal notion dyspnea and diaphragmia.
Anything else? What other pointers in the history and physical findings that tell you this is more likely to be heart failure and not renal failure?
Mm, uh,
Itu sebab dia
but
I give that's why I give you a chance to ask question, right? So that you can think, what else in the history yang tak ada, but I seriously think this is heart failure, but what are the clues out there? So when you attend the class, when you hear the history and physical finding, you must already be alert. What are the clues there that will lead me more toward one diagnosis? Okay.
okay, Prof.
You want to give another name for a friend to help
Uh,
you because it's almost 12 o'clock.
okay, I shall give another name. I just take it from the very top of my participant. Azra already.
Azra, are you here?
Yes, I'm here, doctor.
Thank you, Azra.
So do you agree with your friend that this is heart failure or you don't agree?
Uh, uh, from the first, I agree that this is decompensated heart failure because first he has the underlying ischemic heart disease, and upon physical examination, the if I'm not mistaken, the BP is not hypertensive enough to be renal failure.
So what else do you say is point? So you agree with your friend, correct?
Yeah, I agree with Akir. It is decompensated heart failure.
Again, tell me what are your pointers? There are symptoms. What else?
Or from the symptoms, first he start to have shortness of breath, and second the bilateral lid swelling. It can formation of ascites from decompensated heart failure, and he also having reduced effort tolerance. If and
Okay. What else?
the swelling occur after uh, the non-compliance to the fluid restrictions.
What else? You said something about physical finding also.
Or physical findings. Physical findings about the hyper. The he's not having hypertension, so I think this is not renal failure. And
So let me ask you, because time is short, what do you think of the apex? The apex beat, where is it? Where is the apex beat?
fifth intercostal space at the mid.
No. It's 6 left intercostal space. At where is it?
Axillary line. Axillary
Are
line.
you sure? I still remember where is it. Are you sure you concentrate?
Mid
So are you sure
clavicular
you
line.
concentrate during the? Yeah, are you concentrating during the class or not?
Uh, uh, I
How come?
do
How
not
come
catch
I
up the
can
effect bits.
remember?
I do not catch up the effect bits. I'm sorry, doctor.
So what? How do you interpret this apex beat location?
It is shifted from fifth intercostal
Is it
space to
shifted?
sixth.
Is it very shifted? It's mid clavicular, near the left mid clavicular line. Where is it?
It should
When
be
do you
there
consider shifted?
when it become more lateral to the left.
Yeah,
But in this
it's
case, maybe
mm, if it's a mid axillary line, then maybe yes, it's shifted. This mid clavicular line. Are
yeah,
you
no
are you
shifted.
surprised? You're not surprised. Why?
But the apparently located at the sixth intercostal space, so I think there is maybe sign of cardiomegaly.
Why do you say that?
In normal adult, the apparently should be in the fifth intercostal space.
And then
At the
is that So do you think there is cardiomegaly or no cardiomegaly?
I think there is signs of cardiomegaly, but we need to confirm that with ultrasound or echo.
So why do I ask this question? Why is it important?
Because cardiomegaly can be a sign of heart failure.
So what else do you look for besides cardiomegaly or shifted apex weight? What about the jugular venous pressure? Is it normal or increased in
It
this
will be elevated.
No, in this patient?
In this patient, normal. GBP is normal, if I'm not mistaken.
Is that correct, Manpreet?
Sorry, Azra, can you repeat? I cannot hear you.
Also, as if I'm not mistaken, just now the JBP is not elevated. Is that true?
Manpreet, I think your colleague asking you a question.
Oh, can you hear me? Hello?
Yes.
Yeah, just now I said that the GBP was not elevated. Yeah, it wasn't elevated.
Okay, so what else we expect to hear in someone who has a heart failure?
Parasternal heave,
Parasternal heave? Not exactly. What else?
uh, lung crepitation,
So there were lung crepitations, but it could be part of the so-called fluid overload in this patient. What else are there in the cardiovascular system that you want to look for?
is there any sign of
Any
anemia or
additional
SNOT?
sounds?
Oh, additional sign.
No. Any additional sound?
In this patient, no, but if it is heart failure, it may have murmur,
Yes, you can have murmur. What else? Are there additional sounds that you know? Like S3 or S4? And which one is more leaning toward heart failure?
I'm not sure about that.
Okay, can you go back and do a homework and let me know?
Okay, doctor.
Okay, maybe one last question. Give me another name.
I would like to call for Kirti.
Kirti, are you here?
Yes, Prof.
Let's talk about the stroke. Are you surprised the patient has a normal reflexes in the upper limb?
Normally in stroke, the patient would have an not a usual reflexes in stroke patients.
What do you expect?
Usually they'll have reduced in tone and reduced in reflexes.
Reduce in tone in someone who has a stroke.
Sorry,
So
increase is hypertonia.
can I ask, is this patient having an upper motor neuron or lower motor neuron lesion?
Doctor, it will be upper motor neuron.
Why?
Because the tone just now when Manpreet she presented, she said that the left arm is heavy and slightly hypotonia. So in patient with upper motor neuron, they will have a hypotonia. Hypotonia.
Hypertonia, right? But this patient, your friend say is hypotonia. And it's not just one limb, it's both the upper and the lower limb. Do you think it's correct? And then the reflexes is increased in the lower limb, but normal in the upper limb on the left side. Although they mentioned the patient has a left hemiparesis with a stroke, but the
Doctor,
physical signs are not clear.
normally in upper motor neuron lesions, the reflexes will be hyper reflexes. While
Yep.
in but then from what I understood from previous doctors, they mentioned, but then they say that for upper motor neuron lesion, the tone can be sometimes can be normal or hypertonia, while in lower motor neuron, the reflexes and the tone will be hypo. So in this
For a lot.
patient, the patient is having a hypotonia and hyperreflexia, so it's a upper motor neuron lesion.
Yeah, sorry, just wait for a while. Let me answer the call first. Okay, so I'm being called for the class already, for the next class already. But think about that. Maybe, Kurti, can you do a homework on this and let me know how do you explain the neurological sign in this patient?
Okay, sure, doctor.
All right. Okay, thank you. So please send the attendance to me. Yeah. Hello.
Okay, Prof.
Yeah, okay. All right. Thank you.
Thank you,
Bye.
Prof.
Thank you so
Thank you,
much, Prof.
Prof.
Yeah, doctor.
Thank you so much,
Thank you,
Prof.
Prof.
Thank you so much, Prof.
Thank you, Haifah. Thank you. Thank you. Thank you so much. Thank you. Azra, record kan? Azra record. Azra record. Dah.